We're going to go ahead and get started. The governor's gotten called into something, and he'll be here shortly. This is the meeting of our protection component of the task force. Before I kick it over to Director Toomey, I'd like to ask the Lieutenant Governor maybe to say a few words, and then we'll get started. I will also let everybody know. So we generally I've not done a good job timing-wise, and we've gone over. So that's probably a lot my fault, and I'll take responsibility for that. But I would again ask that as we, if you have comments, things to say, please, just make sure somebody raises their hand because they're controlling the mics over here to the side. Also, everybody should have a mask at their table if they'd like to wear that. We are all properly social distanced, and we also have hand sanitizer. So again, when we take a break or in between things, what I would ask you to do is to, if you're talking with people, please maintain that. I'm looking at Dr. Bell as I'm saying this. I'm saying all the right things, right, Dr. Bell? Thank you. I just want to make sure. Maintain that social distance from folks as you're talking to them. If we go up to the mics on the back side, those will get sanitized in between each person speaking, so that. But we'd ask you not to touch them. All the mics here have been sanitized and everything. So, Lieutenant Governor, I'll turn it over to you.
Thank you so much, James, and thank you all for coming today. We have some distinguished guests here on the monitor, too. I want to make sure everybody knows that they're there. But thank you all for coming today. Yesterday was a very productive day. We had a lot of exchange between our state government and local government and protection, and I think we've developed some great ideas on moving forward. That is the design of the governor, is to have us come together and come up with ways to make South Carolina come through this a much stronger and a much more nimble state than we were in going into it. So again, thank you all for your participation and for coming today. I just look forward to a very vibrant dialogue. Thanks so much.
And Lieutenant Governor, thanks for I'd like to point out, and everybody should be able to see them. We've got Dr. Pastides is on, who is a member of AccelerateSC, and we are still sitting in the house that Harris built, as I like to call it. We've got Dr. Jim Clements from Clemson University is on with us, Dr. Cody Carter from the Commission on Minority Affairs, and Representative Lee Hewitt is on, I see. And if one of y'all, I think Zach is controlling all of the media, so when y'all speak. But now I'll turn it over to Director Rick Toomey.
Thank you, and thank everyone for being here. It is DHEC's honor to be sort of the host for the Protection Task Force. We've got a lot of discussion to go through in a short period of time. And we are looking forward to this information and the participation for everybody in the room. And so with that, I'm going to turn it over to Christian for the charge from the governor.
Well, thank you. In describing the role of this committee, the governor's charter for AccelerateSC said that we will identify protective strategies and protocols for practical statewide implementation to address issues associated with COVID-19 in the workplace and social settings, including the appropriate supply of personal protective gear and medical equipment, surge capacity for medical treatment facilities, and steps to mitigate or avoid future outbreaks as the state accelerates its economic revitalization. These efforts are to prioritize protecting the most vulnerable citizens, including seniors, residents in rural communities and lower income communities, minority communities, and for persons with chronic disease and weakened immune systems. These additional efforts are to include plans for statewide implementation of increased disease and immunity testing, as well as contact tracing. And so, with that kind of mandate in mind, we've put together an agenda that is organized around sort of four main themes with one additional kind of cross-cutting dimension. And so these themes are talking about how to prevent the spread, how to expand our testing capacity and our reach, how should we be responding to new cases, and how should we be improving our supplies of personal protective equipment. That cross-cutting dimension is looking at some of these questions based on socioeconomic factors and sort of the ruralness of different communities. I expect we'll hear a good bit from our coordinating agency today, which is DHEC, as represented by Director Toomey and others, but that we likely won't be able to get through the comments from each relevant agency that's been identified in the AccelerateSC Charter. We will be meeting again during this 30-day period, and for those agencies that have relevant information that can help us in this work, we want to be sure that you please let us know at the conclusion of the meeting today or afterwards so that we can talk about how to incorporate that information in this process, including potentially at future meetings of the task force. We have more work to do than we have hours in the day, and so with that, I'd like to hand it back to Director Toomey so we can get started. Thanks.
Thank you, Christian. One of the things that we talked about and wanted to really have a chance, as Christian said, there's more hours in the day that we need than we have, but wanted to have a snippet of information from each of the response committee members and then the agency members, as if you would introduce yourself, your agency, or who you represent, and one issue that you think is critical that your agency or organization will face in this. And so, Dr. Cole, you represent on two sides. I'm not sure if you want to save your ammunition for the first part or if you want to give that 1-minute introduction and your critical issue.
Well, I'm happy to speak briefly. I would say issues, for sure. I'll take a moment to maybe just to outline what I think would be some relevant sort of framework that maybe we can talk about, and then some details. Under the framework, I would, in my view, and I think from a lot of MUSC Health, and I represent MUSC Health, MUSC president, economic revitalization means that essentially we're moving from shutdown, social distancing, and quarantine to monitor and respond as we move forward, as the overarching sort of mechanism to maintain safely, to be able to safely move forward. So really the focus is how do we monitor and respond appropriately as the economy starts to move forward? What does that look like? The second thought that I would have is that I think it's really important that the economy, the economic revitalization doesn't outstrip our ability to monitor and respond. We have a capability now, but it's not mature. So they have to have a certain connectivity and certain parallelism as things start to roll forward. Because if we don't, there will be gaps and there will be consequences in terms of avoidable sort of infections and hotspots and so forth and so forth. Testing is a major underpinning of our ability to monitor and respond. And I would like to just take a moment at least to make some comments about where at least we understand that we are. And again, understand I've got the lens of MUSC in terms of what we've been doing, but we've been in this foot race for about 6 weeks now. So we're not speaking just out of sort of lack of knowledge. And there's a lot out there, so I think there's a lot of confusing things. So I thought it might be useful to try to at least dissect what we're talking about. The first category is diagnostic testing. That's the test that says if you have symptoms that you have an active infection. That's a PCR-based test. It's a PCR batch test. And we have increasing, I think, capability within the state, and certainly industry is having a lot of capability in terms of volume of PCR tests that we can perform. The three things that you really need to perform a test: you need technical capability, you need reagents, you need a valid platform, PCR machine. So I think a critical next step or steps with PCR testing is that we have to have an ability to coherently understand, assemble, and report the tests. It helps nobody for somebody, Ms. Smith, to pay for an isolated PCR test and know that she's positive or negative. We have to have it aggregated in a manner that's reportable, that's actionable. So the reason I say that is there's a lot of moving parts as I see this now and across the state where people are going to come in, industry is going to come in and say, hey, we can do 100 tests, or we're going to do this for this community. And that's all well and good. It just needs to be assembled and reported in a manner that's actionable. So that allows us to deploy those PCR diagnostic tests to their highest impact, as opposed to wasting it or having it non-usable. The second topic is antibody tests. Not diagnostic tests, antibody tests. Antibody tests essentially show that you've had the virus and your body responded to that virus. Therefore, you have antibodies. there's, I think, several things to tease out of there, because there's a lot out there in the media, there's a lot out from different health organizations saying, oh, they're not valid, we don't trust them, we don't know. So I think there are some things we can easily and readily come to grips with. Let me make a comment. To date, antibody testing has been Wild West. Industry has been coming out there. We are aware of at least 150 companies that are coming up with different tests and, hey, use this and use that, and by the way, selling on the market and so forth and so forth. The first thing is an antibody test valid? Meaning, if it shows positive, did you have COVID? The reason that's a relevant question is because, understand, coronavirus is a common cold. So if you don't have the right proteins, the right antibodies that you're recognizing, you can have a lot of false positives, a lot of noise. So it's a valid concern to throw out there, but I will also tell you it's an easy thing, especially with the reagents and testing capability, PCR testing. We can bump that up against PCR testing and say, hey, yeah, this thing is totally valid, or not. You know, so we can and are currently, I would say we, MUSC Health, are validating tests to answer that question. So that shouldn't be an ongoing concern. You know, we can validate a test and we can show that, yes, if it's positive, that means COVID-19. The second issue is availability, okay? We could have the most perfect test, and if we only have one of them in 3 months, it doesn't help any of us, right? So we would advocate, and this is what we've been doing, we need to have a construct where people are looking at validation of the best tests available and how much we can get available as quickly as possible. It has to be both to be able to get this to be deployable. If you have a valid test, the first question you can answer, which doesn't have a bunch of controversy, is what's the prevalence of infection in our community? How many people have already had this infection? And those, to me, are important things to answer. Why? It affects the big aggregate numbers. You know, we only know what we know. We know that we have X number of positive COVID cases. If we had 10 times as many individuals who actually had the infection and we proved in our communities, by the way, the death rate goes down by tenfold. The fear factor certainly improves. Doesn't mean people don't die, but how we react and what we think, I think, is an important thing that we need to understand. And so we need to validate a test. We need to understand the prevalence in a validated test. The second dimension, which is harder to answer, is the immunity question. There's a hope, I would say, and a logical likelihood, but not proven, that if you've been exposed to COVID, if you show up with an antibody test, and you test positive, that it means that you have an immunity and therefore will not get reinfected. Just to be honest, we don't know that for a fact. That has to be proven. We can prove it over time. If we test patients, we know who had the prior infection, we can follow them, we can understand who does or does not have that, what percent get reinfected. I would say, and this is my Dave Cole bias, it doesn't mean you're at greater risk. It's not a bad thing to be antibody positive. Not a bad thing, but there's a question that we have to answer. So to try to tease that out, I think is important to sort of, because it gets all swirled up and people start throwing 5, 6 things at you. It's like, okay, is it valid? Is it available? What's it tell you? How are you going to use it? And by the way, the immunity question, we need to get it set up and structured so we can answer that for our community. So I think things that we need to think about is, how do we get a valid test? How do we validate it? How do we get availability? How do we deploy it when we get it? And again, those are things that I think will be most useful. I'll tell you that MUSC, as we speak, have been using PCR tests to help our health system and our patients and first responders as first priority. We're going to deploy the same with the antibody test as it becomes available. I think that there is an ability without a gazillion tests to be able to do prevalence studies that you can statistically evaluate, to understand relatively statistically what the presence in the community, and eventually, if we had enough tests available, if we knew they were valid, if they knew what they meant, then we could start test and retest and actually start getting the wheels turning with that as a reagent. That's not a today, that's a future thing, but we have to start somewhere. I'll make one more comment, maybe leave space for our other academic health.
Well, you're setting the stage for the discussion topics. We were going around the room just to give everybody a chance. So you framed your discussion topic really well, but go ahead and...
The only thing I will say is that testing has to have a framework to occur. I think it's really important that we reach our rural communities. And so We have emerging, and again, MSC Health has had a virtual care platform. We have remote testing capability that can be expanded, but we have to go to the people. We have to go to the communities, and we have to be able to provide that testing capability and that follow-up capability. I think that also requires partnership and communication with the community leaders in terms of what that looks like. There's a trust factor, there's an availability factor, there's people that know the local resources, and so we are starting to look at how do we extend and expand our testing platforms to go to what the rural communities need, and how does that actually look in partnership so that we have something that is much more robust for all the citizens of the state of South Carolina. So I'll stop there. Thank you.
Thanks. Is Tiffany Freeman?
Come out of my mask. I am Tiffany Freeman with Blue Cross Blue Shield of South Carolina, and one area that is critical to our organization is the reliability and confidence in the antibody testing.
Thank you. Mike Hamlet.
I'm Mike Hamlet. I'm a pastor for the last 35 years, the First Baptist Church of North Spartanburg. As someone who's involved in the faith community, I think that there's a great hunger, and as a Baptist, which Baptists never speak for other Baptists, but I will. I will tell you that Baptists and members of the faith community are part of the thing is they're saying, what do you want us to do? They are ready. They're ready to help. They're ready to serve, and it's a great opportunity for them as we face this challenge together.
Thank you. Keith.
Yes, I'm Keith Mackey from the Scheffler Group. We're a large global manufacturer for the industrial and automotive OEMs, and we have our headquarters based in Fort Mill, South Carolina. I think my key takeaway, and I think for all manufacturers, is as we look to bring our plants back online and so forth, how do we do it in a way that we can make sure that we're assuring the safety of our employees, but also as we go through and we're working through this, can we continue to make sure that we're providing the appropriate PPE to protect them? And then if we do have a positive case, as the doctor was stating, how do we respond appropriately in those type of actions?
Thank you.
Thank you, Bill.
Okay. State agencies that are assisting with this process, I'll let y'all just take turns. Josh, maybe, I'm not sure if you're the first in the alphabet or not, but you're a B at least.
Okay, that'll work. I think it's really twofold. One is looking at the economic incentives we're putting in place to ensure care is delivered in sort of the appropriate way at the appropriate locus, which is the underlying value proposition of the agency, and just continue to gauge the appropriate time to push on or release off the incentives and temporary measures we put in place. And then the flip side of that coin is really understanding in this new world the cost drivers of our provider network so that we're reimbursing and addressing those needs appropriately throughout the response in sort of reentry and reopening. So those will be our sort of core challenges.
I'm Emily Farr with the Department of Labor Licensing and Regulation, and particularly with this group of thinking of the protection side of task force, I would say one of the biggest challenges we have is getting the right information together and out there, because our agency has a licensing side. We license pretty much every profession in the state. So we have a lot of people that come to the agency looking for information about how to make their business safe, about how to reopen and what that looks like. And then we also have on the labor side the state's Occupational Safety and Health Administration, where we provide that guidance to keep employees safe, less so public, but making sure employers have the right guidance to make their employees safe there. And then we have state fire with first responders responding throughout our state as firefighters. So I think when you look at all of the gamut of what our agency provides both to the public and to our customers is the information. It can be really confusing to know what folks need to do to protect and what it looks like when we do start to reopen businesses, and making sure we're providing the right information is really key, I think.
Thank you. Senator, I'm going to come back to you after.
Sure,
let you have the last word.
No, I'm just here to listen and learn. Thank you, Rick.
Sarah.
Thanks. So Sarah Goldsby with the Department of Alcohol and Other Drug Abuse Services. Clearly the key for my agency is to focus on our already vulnerable citizens who use substances, misuse substances, and have addictive diseases. They're at a heightened vulnerability under this crisis with the susceptibility to contract these diseases, particularly those who use inhalants, tobacco. We have a lot of folks who use tobacco in our state. Methamphetamine and other inhalants really do make them more susceptible and at a higher risk of mortality. I think there's a lot of information to share, particularly with that. And then with the isolation and the social isolation we've been seeing over the last few weeks, we've really seen a lot of social norms in social media and in our networks with folks in recovery and folks who have never had an issue with alcohol use disorder. Alcohol use is up. Social norms are being set to say that, you know, margaritas are the new coffee. Working from home makes it acceptable to start drinking at noon. And I think this is going to impose some challenges, particularly with the workforce, with folks who have never have otherwise crossed the threshold into a substance use disorder, an alcohol use disorder. And I think our messaging at this time is key to protect those folks and to protect our future workforce.
Thank you. Michael. It's on.
Hello. All right, there we go. Mike Leach, Department of Social Services, State Director. I mean, I kind of echo what Director Goldsby said. You know, our vulnerable citizens right now, making sure that we're addressing all the new stressors that come with the pandemic, the financial instability, the lack of resources, the lack of social support. You know, my potential caseloads that I have for foster care, child protective services, adult protective services, SNAP, TANF, all of those have already started increasing and are going to continue to increase. We have some lulls in child abuse reporting and things, but when we open this up or things become more open, we are going to start seeing those increases of those things. And it's happening right now. The damage is being done. And so we need to be thoughtful about how we protect our citizens, but also the current stuff that may be happening with the isolation and other things. And you know, people are struggling right now, and we're trying to address all of those needs. So we have to be thoughtful what that looks like as we open this up, but also make sure we're protecting folks.
While we maybe take us clean to the microphone, Dolores DaCosta.
Good afternoon. I'm Dr. Dolores DaCosta, the Executive Director for the Commission for Minority Affairs. We have a lot of different issues that we have to deal with. We represent the African American, Native American, Hispanic, Latino, and Asian communities. Some of the major issues that we're facing right now, we're working with DHEC as well as with DO, is how to get information and get folks who are undocumented to be tested in the Hispanic community. Our Native American communities, there's a trust issue there. They're not going to trust anyone coming into their communities. How do we get that message across to them that we are here to help preserve their communities? And of course, in the African American communities, rural isolation is a major issue. If we do not get testing, or if we ignore those populations in those areas, we could end up with hot spots of untested folks recontaminating areas. So those are some of the things that the Commission's trying to keep in front of folks. We help to disseminate information. We translate information in other languages to make sure that folks can understand what's available to them, what to do if they have symptoms. But it's a hard task because a lot of these folks live in rural areas.
Thank you. And I'm aware of the individuals on the screen. We'll get to y'all, but next.
Good afternoon. I'm Connie Munn, the director. I'm sorry to have to touch the microphone. I've got to bring it down. For the Department on Aging, and I just want to thank you for the opportunity to come here and meet with you. I think, echoing what our other state agencies have said already, we serve the most vulnerable population with the elderly. So we touch them in many ways on all of the services that they receive. And one issue I think that's critical as we're moving forward in opening up the state is looking at public transportation. That is how our seniors rely heavily to get to any of their services. And as we begin to open that back up, I think we need to be aware of it and how we can continue to protect our seniors. Also, that's how they get to their medical appointments, and they're very socially isolated as well. Another point is we've been able to, and I appreciate the grocery stores and other shops having special hours for seniors during this pandemic, and I think that it would be key if we could continue that afterwards, to have those special hours so that the seniors can continue to go and shop. So those are just a couple of areas that I think would be helpful to us to protect our seniors moving forward as we open up the economy. Thank you.
Thanks, Connie. Kim?
Yeah, good afternoon. Kim Stenson from State Emergency Management. I think a lot of you already know, but I'll mention it anyways. Our primary mission is to assist the governor in coordinating the state response to emergency situations. Most notably in the recent past, it's been hurricanes and floods and tornadoes. But right now, it's this particular issue, the COVID-19 operation. And in our particular world right now, one of our priorities is the obtaining of additional personal protective equipment, not just for, of course, the state, but also, very importantly, the local authorities and also, you know, some of the private medical facilities and that sort of thing. So that's one of our major objectives and one of our major concerns.
Thank you. Maybe alternate microphones. Up. Give a chance for a wipe down. James, thanks for having two. That works very well.
Hey, I'm Bill Kirkland. I'm here.
Please.
Go ahead, Jack. I'm Bill Kirkland. I'm here for President Castleton, University of South Carolina. The one thing I like to stress, and Dr. Cole and Dr. Clements and Mark Ahala and President Castleton have been leading a working group. I don't know if you're aware of it, but there's 4 separate teams working across the state for Dr. Cole the last 6 weeks, having weekly calls, but also there's a Rapid Innovation Task Force led by Prisma and USC and Clemson, along with Dr. Cole's team, really looking at 4 specific areas: bioengineering innovation, which you might have seen when we actually had a ventilator technology that was fast-tracked by the FDA through our medical school in Greenville, which basically gives you the ability to use 1 ventilator for 2 patients. It's really, it's exciting. We can forward you that information. But also clinical data collection and clinical trial development, epidemiology and data monitoring, and testing capacity and diagnostics and serologic, which Dr. Cole just mentioned. I just stress that we need to continue to use these experts. There are 4 team members on each group. So you have a large group of experts that are working daily on conference calls, but also every week, and feeding back up to Dr. Cole, President Caslin, Dr. Clements, and also Mark Ahala. So as a group, the university and the major health systems have been working together for the last 6 weeks, and we continue doing that. So thank you.
Good afternoon. I'm Janie Davis with the South Carolina Human Affairs Commission, and I represent, on behalf of the state of South Carolina, the Equal Employment Opportunity Commission, the Department of Housing and Urban Development, and both of these organizations and how they contribute to the state of South Carolina is very important. The first issue that I would like to bring to your attention is the issue of employment and how the issue of employment and this virus are interconnected. We have so many people right now that are not working, of course, in their place of employment, and they don't know whether they'll be going back to a position. That means that possibly we will get allegations of unlawful discrimination based upon the fact that someone may have discriminated or believe that they've been discriminated against because they either had the virus or they may come back into the workforce and exhibit symptoms that may make someone think that they have the virus. So that means that that is a real concern in the employment area. Also, as it relates to public housing, we are the agency that would investigate any allegations of housing discrimination, because if a family or a person in a family has been diagnosed, or maybe someone thinks that someone in that family has been diagnosed with the virus, are they going to treat them differently? Will they want them to move from that housing complex to someplace else? So you can see how even after this is over, there could be long-term implications for people who either had the virus, you know, they might suffer another issue. Another area that we are involved in is community relations. As you have heard, there are definitely disparities related to the populations and who's being impacted by the virus. That can also have implications for community relations. What will happen in the communities once this ends? We have communities where certain populations live on certain sides of town, other populations live on another side of town. Will that hinder their interaction and the working together of those populations? So those are issues that we will be looking at and addressing from the South Carolina Human Affairs Commission. Thank you.
Good afternoon. My name is Ken Davis. I represent South Carolina State University. First, let me say thank you for giving me the opportunity to be in a meeting with people and not looking at a screen. This is my first actual meeting since March the 10th where I get to actually be around people. So that's very appreciated. Our focus has been and will continue to be the prevention and spread of this. So I'm the Director of Facilities for the university, so we're focusing on what does the new normal, what's that going to look like? How do we bring students back to our campus safely? Will we house them? If we do house them, how many will we house? What's the new learning classroom going to look like? How many are going to be in that classroom? You know, how available will the disinfectants be? We ordered equipment and chemicals on March the 3rd to be able to sanitize our campus. They're supposed to be here this week. Hopefully they arrive, and we'll get to do that and moving forward. But we're taking every step that we can to make our campus safe and to be able to hopefully bring at least some of our students back to campus in August if we keep moving towards opening.
Thank you.
Good afternoon. I'm Mary Poole. I'm the State Director of the South Carolina Department of Disabilities and Special Needs. I don't want to say that we care for the most vulnerable of the state because we've said that a few times, but we do care for very vulnerable people. We operate 5 regional centers, and we also have about 4,800 people that are living in the community in community group homes. To date, we have 22 individuals in the community who have contracted COVID. We had 2 fatalities of individuals with quite a few underlying medical conditions, but all the other folks are recovering nicely, I'm glad to report. In the centers, out of the 5 centers, we only have 1 center that actually has positive cases of COVID, which is amazing. We have 17 cases in the PD area, which is in Florence. So we know that's kind of a hot spot. So our staff, we also have 17 positive staff members besides the individuals. So given the numbers of folks that we support in those centers of 700, we're very positive. And they are all recovering at this time. So our worry going forward is to the health of our caregivers, the health of our direct support that are going in every day, which I want to give a big thank you to, because in the face of all this negative press, they're going to work every single day. And they're going in and they're doing care. And you can't do feeding somebody or bathing somebody from a computer screen. You have to be there. You have to be right near that person. So they're doing a great job doing that and keeping healthy at the same time. But we also have to worry about our provider community and how do we come back from this, as everybody has said. As you open up businesses, we have to think about the families who are caring for loved ones whose group work setting has shut down. So how do we open those settings? In the same way, how do we open child care settings? We need the care for the parents so they can go back to work. So we have to look at that. We have to look at provider capacity and provider willingness to go back to serve. You've got some, because our service is a person-to-person service. It's not something, again, you can do forever telephonically. We do have to go in and see people. So if I was looking at the concerns for our agency, it's how do we build capacity back and how do we get people back without being afraid?
Ken Rogers, Director of the State Department of Mental Health. There are three populations that we're really most concerned about. The first one is, of course, our elderly population, especially those in nursing homes. As many of you know, Department of Mental Health actually operates 4 nursing homes around the state, and thankfully up to this point we've not had any positive COVID cases in any of our nursing homes, which is really a blessing on our part. But the social isolation that goes along with that for many of our seniors becomes a huge issue for us. Second population is the homeless population, many of whom have seriously and persistently mental illness. And because of that, many may not have homes to go to at night by definition, but also may not have many of the things that we would take as, our day-to-day operation, including food and shelter, et cetera. The third group is really our seriously and persistently mentally ill population in general. As we know, with the increased stressors that we now have in our population, especially with kids, what we're seeing is an increase in psychosis. We're seeing an increase in depression across those groups, and so we've remained open to try to continue to provide services for those populations. But the other group, and the one that I worry most about, is those who have never been diagnosed with a mental illness prior to COVID. What we're seeing is lots of folks with anxiety. Imagine being in a house for long periods of time with young kids. You may have some minor symptoms that are there, but now those are beginning to really flourish in ways that we haven't seen before. We all, of course, this week heard about the physician who killed herself in New York. And what we're now beginning to see and worry a little bit about is the number of health professionals who have now worked with COVID patients that now are going to have PTSD and other symptoms that we're going to have to really begin to deal with over time. And that will certainly be a population that we will continue to focus on as we move forward. Thank you.
President Clemens.
Thank you for the opportunity to join you via WebEx. And first, let me just start by saying it's really nice to see all of our colleagues coming together to tackle this problem for the state. And as Bill Kirkland very nicely said, MUSC and David Cole and University of South Carolina and Prisma have been working together really for the last couple of months on a whole array of opportunities that can help the state. We face the same challenges that we just mentioned by my friend at South Carolina State, how to reopen testing of our students, testing of our faculty and staff, how you space students in classroom and labs. We offer opportunities that help the state move forward specifically, and I go through them very quickly. 4 areas. One project is a Healthy Me, Healthy South Carolina project that we're doing with MUSC, and that's really taking our extension team, works throughout the state, going into rural and underserved communities that could be for testing or any other support that they might need. The second is we're doing a lot of serological testing with the potential to do a saliva-based test that would really show who has antibodies and who doesn't. And that could be a bit of a game changer. That, again, is with MUSC, who is playing a key role in that. And then with our partners, again, who we're working with the ability to do testing of urine or waste streams to test to see if the virus is in the urine or in the waste stream. And the last thing, fourth thing, is contact testing, the ability to do digital contact testing with instant alerts to people who have been contacted with someone who has tested positive for the COVID-19. So, hey, look, we're ready to help in any way we can to deploy our resources for the good of the state. And the best way to do it is with our partners, those who are on this call, and those like NUSC, Prisma, and University of South Carolina, who we've been working with very closely.
Thank you. And Cody, I know that you're going to be presenting a little bit later, so Dr. Pastides.
Well, thank you, and good to be with everyone. I'm not representing higher ed this time, but I do chair the board of the Institute of Medicine and Public Health in South Carolina, and we are busy, frankly, documenting what we can learn from this pandemic and our responses so we can create a policy document for the state, for the governor and the General Assembly, and really all the people about how we can do better next time, because we must always try to do better. And beyond that, I have been a senior advisor to the World Health Organization, being a lifelong epidemiologist, so I'm remaining plugged into advances in technology that may be apparent, and we'll be happy to be passing them back on to this protection. So happy to be with everyone.
Thank you. Does that catch everyone? I want to thank everybody for those moments, the stories that you shared, because you helped emphasize the importance of the Protection Task Force. We have a lot of issues to get to where we're coming out of this pandemic, and as we move to that accomplishment, you've helped highlight from your agency, your organization, the factors, the things that we should also keep very much at the forefront of our efforts, and why we have those efforts going on is to help us get back to that new norm, but to help protect and address those issues that you've brought up. So again, thank you very much from the task force for sharing that information. And if Christian, I'll turn it over to you to call on our first two facilitators.
Well, thanks. I think we were going to lead off with some thoughts about actions the state can take or can encourage others to take in order to help prevent the spread. And with that, I think we were going to throw it to Drs. Pastides and Bell.
So I'll defer to Dr. Pastides first.
No, go ahead, Linda. Go ahead. You're right in the thick of things.
Thank you, Dr. Pastides. I was only going to make some comments about the foundations of preventing disease spread, which is the ability to be able to perform adequate surveillance so that we can detect cases and respond to them for disease prevention and control measures. And for COVID-19 in particular, measures that we don't typically take, we do for some infectious diseases, but the need to isolate cases because we currently have no effective vaccination, no other effective treatments, and no one in the population was previously immune. So the need to do isolation around each identified case was very important in preventing the spread early on, and to conduct contact investigations around each case so that we can also take measures for those close contacts and place them under some restrictions like quarantine for about 14 days, the time frame for the incubation period for the illness. So the ability to conduct adequate surveillance is the foundation of preventing disease spread. And our prevention methods are based on our knowledge of how a particular virus is spread. So for this one in particular, a novel virus that we're continuing to learn about, we are early on had made assumptions that this is a virus that is spread by respiratory droplets. And what we know about the behavior of respiratory droplets is the reason that we have people spaced out in the room the way we are. We say 6 feet apart because that's how we believe respiratory droplets can be spread. And the other factors about this, we believe that contacts were based on having close contact with someone who had symptoms and for a certain duration. But as we learn more, we have suggestive research that says that this particular virus may behave differently, not like a respiratory virus alone that's spread by large droplets, but it may have an airborne component where those droplets can actually spread farther than what we believed and stay suspended in the air for longer periods of time. We are learning more about the possibility of people being able to spread the virus before they develop symptoms or even in the absence of symptoms. We're learning more about other potential modes of transmission. So someone has already mentioned it may not just be respiratory droplets, but we have identified that the virus can be spread in the stool. And so what are the implications for control measures like that, particularly in settings like a nursing home setting or something? So as we gain knowledge, that has to inform the prevention measures that we recommend. But for now, based on what we do know, taking the protective measures, regardless of the relaxing restrictions or normalizing, our goal is the protection of the public health, and economic recovery is part of that, because economic stability is one of the social determinants of health. So everything that we can do to support economic recovery ultimately also supports the health of the public in general. And so as we're making decisions about relaxing restrictions, we still have to keep in mind, as many of the state agencies have mentioned, how to do that safely for their workers, for their patrons, having adequate information about return to work, safe environments, higher ed, making sure that students can return to school safely, and the measures that we need to have in place to be thinking about before we start these reopenings to make sure that we don't put anyone at risk and that we're not in a position to see a rebound. Mm-hmm. So another foundation of being able to be comfortable with these reopenings goes back to adequate surveillance. If we're looking at our disease curves, to take prevention measures, part of that prevention is making sure that we are adequately detecting cases in all the communities. And I think the final point that I'll make about prevention of spread is that when health disparities exist, and particularly with an infectious disease, if there are pockets in the community of any cases that are undetected, it does put all of us at potential risk for exposure. And so assuring that access to care, access to adequate testing, to give us the ability to detect and respond to cases and prevent spread are the foundation of our public health measures.
So if I may, Dr. Bell, I hear in your description a somewhat incremental approach, and that there are certain settings and environments in which you would expect restrictions to remain in place longer than others, right? So, for instance, we heard about one of DDSN's centers a few moments ago. I know that nursing homes have been a site of particular concern, throughout the country ever since the very beginning. A number of hospitals have also adopted more restrictive visitation policies. It sounds like you're describing a sort of an incremental model over some period of time where restrictions come off in some places before others.
Yes, and not just incremental, but the prevention measures that are necessary are also site-specific. So, nursing homes are a special setting. So regardless of what we're doing with reopenings in retail settings, the measures that are necessary in congregate settings are really unique, not just nursing homes, but in all congregate settings where people are in close proximity. We don't have the ability to social distance or cohort. So it is incremental, but also site-specific.
Thanks. And I know Dr. Pastides has also talked in some settings about sort of a matrixed view of when we might expect to reopen and how we might decide to reopen. And Dr. Pastides, I don't know if you wanted to elaborate on that theme as well.
Yes, briefly, although Dr. Bell did an excellent job there. I wanted to mention that we need to be speaking not only about, when to reopen, but also specific subgroups of the population. In other regions, in other countries, people are talking about some kind of, coronavirus passport or immunity passport. I don't like that idea. It's not a South Carolina friendly idea, but the point being that in our society already, we have those who have been ill and are recovered, others who are immune for other reasons, have been exposed, others who generally have great immunity levels because they're younger and more vigorous. And then as you get down the other end of the ladder, people who are in institutions and infirm. And so I think as we advise government on allowing people to return, it shouldn't just be how important their work is for society in general. To compare a public safety officer with someone who can work equally well at home, that's pretty obvious. But also we want to keep those people, as we've been talking about, not only in institutions, but who are going to be more susceptible to both infection and to serious infection and mortality. We want to keep them home longer. The other thing I want to mention is contact management that's been spoken about a lot. That is so critical that we need to already be mounting like public service announcements and campaigns to let the public know that people who are sick or who infect people unknowingly are not bad people. We can't turn citizens against citizens. We've got to begin educating the public so that they would know that if they're contacted because they were exposed to a newly infected individual, that they must cooperate. We're not turning people against people. So it's not early to begin thinking, even within the protection subgroup, a communication plan or recommending to the South Carolina government a communication plan about what they will be obliged to do as citizens to help us all get to a better place.
So one question I might have for Dr. Duvey, and as I pose the question, I am chagrined that I don't have my mask on. It's right here, and you have your mask on. But as we talk about preventing the spread, and as we talk about reopening even in phases, how important is masking?
I'll take it off so I can be very clear. Masking, I believe, and the CDC believes, is critically important. As you heard from Dr. Bell, there's a lot of science we are yet learning about droplet spread, about size of droplets, about even emitting droplets through the simple act of breathing. So if I walk into a grocery store and the arrows tell me I have to go in one direction and I'm following 6 feet behind somebody else who is not wearing a mask, and that person is simply breathing or sneezing or coughing, and there are particles that remain suspended in the air for 3 hours or longer, and they may travel 6 to 9 feet. In fact, COVID-free zones in hospitals were cultured, and there was virus. So no known patient or staff with COVID-19 disease in those areas, and there was virus. And the question is, how did the virus get there? Well, chances are fairly good that it was spread through the air. So knowing that, and knowing that I'm going to be following behind somebody else, I'm going to wear a mask because I feel that I need to protect myself, I need to protect my family. What would be very helpful is if the person 6 feet in front of me also wore a mask. Because we know that masks are not perfect. These masks offer some level of protection, but it's not complete. So the more of us that are masking, the less likely it is that we're going to be sharing virus with one another, even inadvertently, even through the life-sustaining act of breathing. So, and that's a beautiful mask. Made lovingly by somebody from the Department of Corrections.
Yes.
Yes.
Department of Corrections gave me one.
Yes.
At least it doesn't have property of.
So I do feel that that's something that perhaps we don't talk about nearly enough in public health. It's a recommendation that came late from our friends at the CDC. We saw friends in other countries masking long before the recommendation was made for us here. And in fact, we were actually told it's probably more harmful to mask than not to mask, because you may be touching your face, you may be messing with your mask and inadvertently spreading virus or infecting yourself. I'm glad that my friend and former colleague, Dr. Jerome Adams, actually did come out and say, you know what, we all need to be masking. And I think what happened was the science just became clearer. We began to realize that 50% or more, we're not really sure, but several studies have indicated about 50% of individuals who are infected with COVID-19 actually have no symptoms. That we can spread COVID-19 2 days, as Dr. Bell said, 2 days prior to symptoms if we develop those symptoms. So you may be at any point in time next to somebody who feels fine, who you know, has taken their temperature, who never develops a symptom. And so really, in order to offer a higher level of protection, because the only true level of protection is staying in a bubble, which we can't do, and it is to wear a mask, wash your hands, do monitor for symptoms, stay home if you're sick. But what we can do when we are healthy and out and about as we need to be is wear those masks. So I'm going to put mine back on.
No, I should probably say then, too, for the benefit of the streaming audience, that many of us have been wearing our masks when we're not sitting in front of the microphone. Yeah. So I don't want any of us to get too many demerits for having tried to be
no judgment.
Clear on the mic anyway. The I mean what I've heard, I mean, over the course of the past few minutes, I think is you know, an expectation there's going to need to be a pretty comprehensive approach to contact management. You know, beyond our current resources, that will need a targeted approach for a variety of different vulnerable settings, or settings in which vulnerable people are, I suppose is maybe a fair way to put it. You know, I've heard thoughts on a communication plan that elements of this need to be probably presented to the community in a more, you know, maybe approachable way that meets the needs and expectations of the folks we're talking to. I mean, I think in public health we're used to talking a lot about meeting people where they are. And there are probably elements of this strategy that we haven't necessarily been that successful about yet in presenting in the right way. And I've heard just a number of different versions of a site and setting specific approach, right? That you know, at least on this sort of first theme about preventing the spread, that we'll need to organize our efforts in that kind of way. You know, before we move on to the second theme about testing capacity and reach, anybody else anything else they'd like to add on that first dimension?
One big concern that I have for the populations that we serve, many of them have several generations of people living in the same household. And trying to educate them on social distancing it's almost impossible. How do we get that message across? Because if you live in a household, there are grandchildren, parents, grandparents living there. You have people leaving the house every day, coming back into that home. I see that as a potential risk factor, and it has to be addressed. Many of these families, particularly in my Hispanic population, many are non-English speaking folks. We do a good job of translating. We have several bilingual people on staff. We even have contracts with folks who transcribe all of our literature and what have you in Spanish. But the message is not clear, because in that same household, you're going to have someone who's undocumented and they don't want the attention on them. How do we protect those who they're exposed to when they leave the home, as well as protect those who are living in the home? It's a tough situation.
Could I speak on that? And I'm gonna speak from having worked with the Disaster Recovery Office after the floods, when we were dealing with how do we communicate with people in our rural communities. And one thing we found, and I'm pointing over towards Dr. Hamlet, is in our faith communities, a lot of people may not trust government, but they trust their pastor, right? And so our faith communities were critical to helping to disseminate information to people as we were looking at finding out if people had damaged homes. And so I would encourage you, as you think about that, to talk to Ben Duncan and his team at the Disaster Recovery Office, because they've got the roadmap, the blueprint for working through our faith communities to be able to communicate with people, because oftentimes we saw that they will trust their pastor, and those were critical avenues of disseminating information.
And we do. We work with the SC emergency folks, and we also have partnership with a lot of pastors and churches around the state, because we know that's a critical element in every community.
Yes, ma'am. Senator Davis.
I've got a question, an observation to make. I think it might be the appropriate time to make it, not directed to anyone in particular, but looking at the data, it seems to me that we know two things, or more than at least two things. First is, and this to what Dr. Cole had said earlier, that the fatality rates are not as severe as was once thought. As we get through these antibody tests, or the denominator gets larger in regard to the number of people who have been infected relative to the numerator, which is the people who have died, we're getting to a point where I think it's below 1% in many instances. That's the first thing I think we've realized. The second thing is that the fatality rates are dramatically different for different categories of people. Okay, I think it's skewed very dramatically toward either those older than 60 and or with underlying conditions, and that those under 60 without underlying conditions, the fatality rate almost goes down to zero. Given what that data tells us, what strategies are we developing and what recommendations are we going to make to the governor that allows those who can safely enter back into society and engage in economic activity, while at the same time ensuring that we protect those who are vulnerable? Because thus far it seems like we've dealt with a broad brush treating the activities of individuals uniformly, when those two data points suggest that a more measured approach, or one that's more responsible, would recognize what that data tells us. Because as the doctor has told us, there are public health implications to the damage being done to the economy. And I'm just wondering, since we're talking about protection, are we going to recognize what those data points tell us and develop strategies that are more targeted and avoid that consequential damage or ancillary damage to the economy, which leads to more health problems?
So I think the way I would answer your question, I think the way you saw the governor roll up as we were kind of putting some measures in place in I don't want to use the term progressive necessarily, but in a measured approach to doing that. And I think what we've seen, what he's done over the last week or so, is to unroll the measures, if you will, similar to the way that they were rolled up, which has been a measured approach to make sure that he is being very mindful of look, the economic revitalization of South Carolina, while at the same time keeping people safe. And so I think that, as I said, as you saw last week, and as we will continue to see, he has made those decisions based on the science, and based on also trying to do things in a measured way, so that it's not, hey, we're just going to open up the barn door and, hey, good luck to everybody. And that's not the approach he's taken. And largely, again, I think that's why this group has met together, right? So that we can help to properly give him some counsel on, hey, here are some of the issues. But I think that he has largely moved in a measured approach. And we saw it last week, we've seen it this week, and I think we will continue to see that.
James, I would agree with everything you just said. I think, and that's another, something else the governor has wants with this group, is that if we do see a spike come up at some point, or if we do see cases going up somewhere down the road, we want to make sure we have good procedures in place going forward, so we never have to come back to this kind of complete shutdown and drastic distancing. So I think that, again, is one of the challenges that was brought to this group, is how do we do it and never have to come back here again. So that's why it's so important in the coming out of this and the rolling out of this in a tempered manner, is to make sure we're setting ourselves up for success and making South Carolina stronger moving forward. But I do have a question, and I think Dr. Cole, you talked about testing people and getting out to the communities, especially our rural communities, and doing testing. And just to be clear, because I think, I listen to Dr. Bell every day, and Dr. Bell was very, she was very, when I say deliberate, when she talked about not testing unless you had symptoms. We don't want to be testing people that aren't showing some kind of symptoms. Now, when you're talking about going out to the rural community and doing testing to give people confidence, are you talking about going out to the rural communities and testing people you think have symptoms, or going out and testing them more widespread?
I think that the first thing to do is to have adequate ability to test for people that are high risk and therefore symptomatic with a diagnostic test. We don't have that fully capable in rural communities. So I think that'd be the first piece. I think that Senator, I agree with everything, your observations. And I think from my perspective, we have to reach an imperfect balance where good is good enough. And to me, we have to stay within the boundaries as we move forward. And the boundaries are, from a healthcare perspective, that we don't put ourselves in a position to overwhelm our healthcare facilities and systems, and we monitor and adjust so we avoid that possibility. So if we have a hot spot, we manage it. We can deploy, we got contact tracing, we can get there, we can do it, right? I think if we expect perfect, it's just not achievable. And I'm not somebody who's advocating for anything that's other than the best we can accomplish. But I think what I'm saying is that as we move forward, there will be cases that come up. There will be hot spots. We have to be positioned to keep and I said this the other day, keep our car down the middle of the road. And therefore, we keep moving forward. I think it's really important that we move forward. But we have to do so thoughtfully in a structured manner with the resources that we don't outstrip our ability to manage. So when I made the comment earlier, and I'm sorry I was maybe dove too deep in the first go-around, we're going from quarantine hunker down to we need to start moving forward, and we need to do that in a monitored way that we can respond and keep things where they need to be so we can continue to move forward. I think it's really important. If we actually allow things to get to where overall systems, then we're going to start having higher mortalities and things that are avoidable and so forth. So the things that we have been talking about, and I think these are appropriate. I would welcome anybody else's thoughts on this. Have leading indicator dashboards on prevalence, leading infections. Infection is a local issue. It's not a statewide issue, meaning hotspots show up in local communities, right? We have to have ground level ability to react to those and keep those appropriately managed. If we can do that and continue to move forward, we'll be successful. I would just make one more observation. I think it's remarkable we're sitting here at this point in time with actually as a state great numbers. I'm not cheering, but I'm just saying that despite all the sausage being made, we actually are doing better than you would anticipate. That we have lower rates in this state at this moment. We have a window and grace to actually do something, and we need to move forward in a thoughtful manner. That's my perspective. We need to move forward in a thoughtful manner, and we just got to keep it down the middle of the road. So we have to have the mechanisms. That's why I keep harping on testing and follow-up and having the structure now. Because if we get too far down the road with people doing the well-intentioned things as companies, we're trying to do this, it's not going to be perfect. It's not. There's going to be situations where somebody goes home and they're living with grandma and they've got 3 generations. It's going to happen. We just have to have the ability to manage it. If we can do that, then we'll be fine.
James, can I ask Dr. Cole a follow-up question about that?
Yeah.
You mentioned it earlier, and I had read about it too, that the statistical modeling and prevalence testing, and in terms of having the test being given to a representative sampling of South Carolinians, to the degree that we can then extrapolate and then make various assumptions based on that. Have there been strategies adopted either by MUSC or DHEC to do that sort of sampling over a representative demographic of South Carolinians so that we can have confidence in that extrapolation and that prevalence showing?
I cannot speak for Dr. Bell. I'm sure that it's somewhere down in the future path. We have actually some clinical studies looking at the initial validated, small aliquot validated antibody studies that we can look at in the populations we have access to, so at least we get some understanding. I think prevalence is an important question because it helps frame the magnitude of the issue, and it helps us put in the context of what we're trying to do. Doesn't mean people don't die. I'm not saying that, and people get tired of hearing this in terms of comparison to the flu, but a lot of people die from the flu also on an annual basis. But we have it in a way that we can manage it, and it's appropriate. So we need to get this genie back in the bottle in a manner that we can manage it and have it appropriate, and it doesn't kill our economy.
Can I ask Christian, from the hospital perspective, kind of where were we, where we are right now as far as bed management, that kind of thing? What has your observation been?
Sure. I mean, I think we talked about dashboards, I think, a minute ago, and there are any number of different ways to try to track the number of cases you have and the severity of the cases you have, right? Each of us have talked at some point here today about managing by data, right? About sort of data-informed decision-making. And one of the first things you have to do, I think, when you make decisions that way is be honest with yourself about the quality and the limitations of the data you're working with. So when we look at hospital involvement in cases and how much it tells us about cases, it tells us about the cases that make it to hospitals. There are a number of people who have honored the advice of public health authorities and have quarantined at home when they had symptoms, and many of them never wound up occupying a hospital bed. And so there are folks who've had COVID cases that if they've had a test result, we might have a test result. But if they've occupied a hospital bed, we have a hospital bed stay to sort of track. But in many cases, there are others who've been affected in the community and stayed at home, and followed the advice they were given, and may not have ever quite made it into a hospital setting. I mean, for our part, I mean, there's a couple things that have happened on the hospital front. One is because we knew we had so many vulnerable individuals in hospitals, we adopted very restrictive visitation policies early on to make sure that we weren't responsible for spread. We'll talk more about protective equipment, later this afternoon, and especially in the earliest days of this, there wasn't much of that to go around, and having more restrictive visitation policies was a way to conserve the resources we have. We did stop elective procedures about a month ago, and for the past month have had bounces around on any given day, but typically about 5,000 beds vacant, and we've very gradually and incrementally, in a very responsible way, have started to handle some urgent cases again, not moving all the way down to, sort of fully, truly elective procedures, but have started to move into things that it felt appropriate to delay a month ago, but which are the kinds of things that can't wait another month, each member of South Carolina's hospital community has been, gradually moving back into that space, and a few hundred more beds have been used along the way, but we have substantial capacity available, and we'll make sure, throughout this that the capacity remains available.
I'd like to, Governor, I know you were at a emergency SPA meeting, but I didn't know if you wanted to speak to the group at large. We've had a very, I think, a good and healthy discussion from folks regarding testing, regarding some of the challenges they're facing, also about protective measures. And I think largely one thing that we've seen and we're hearing is data is important, right? And one of the things that the governor with the AccelerateSC, one of the components that we often don't talk about is the information component, which has been important to him for a very long time, which is how can South Carolina citizens come to a portal to find the information they need, not only related to COVID, but related to various issues of whether it be, what are some protocols I should have? And I think Emily has mentioned this, or Director Farr. I know her as Emily. But Director Farr mentioned about, protective measures in the workplace, and somebody may not know where do I go. And so that's been that's one of the important components of AccelerateSC and Tom, I think that answers some of your questions too, about, how we can keep people informed and citizens informed about the things that are happening, or if they need things as we continue to move forward. So I'll turn it back over to Christian. I don't want to take over your...
Well, no, thanks for that. I mean, I think, maybe staying on this theme of the data, I know something that, sort of two related things that several of us have had a chance to talk about over the course of the past couple of weeks, couple of months. There are cases where we see things that materialize in these curves that we report all the time that require further explanation, right? So we have out-of-state laboratories that occasionally send us a week or a month worth of results all at once. And then we're explaining why we appeared to have one really bad day suddenly, and so that becomes one of these data artifacts. And potentially there's a recommendation or some kind of action that can circle around with that. Another is, the sort of charter, the commission to this group talks about a short, intermediate, and long-term horizon. And of course, you go back to the very earliest days of this outbreak, and at that point we had an unknown number of cases and effectively no testing capacity, right? And then, of course, CDC came online, state lab came online, several hospital systems developed their own in-house capabilities, the reference labs, LabCorp and so forth, Quest. So we're rapidly growing this testing capacity, and that capacity is rising towards society's demand, right? It is slowly sort of moving up towards the amount of testing we need that will let us get into more, community-style testing. But there are things we are missing along the way. So one is some of these new tests that have come online have significantly lower sort of degrees of confidence than some of the earliest tests we've seen. And I think one of the things that we'll have to figure out, and in terms of what kind of recommendations we can come around, are how do we make sure that the tests that are out there are valid, and that we're not just getting as much capacity of any type as possible, but that we're getting more capacity of tests that are reliable and that we can believe the results in. And two, as more and more labs start to conduct these tests, not all of them are reporting their results into a central repository. And I know one of the challenges I've heard from a lot of different elements of the provider community over the course of the past couple of months have been, I ordered another test. We have a limited supply of tests available, and we'll have a provider who winds up ordering a test for somebody who they didn't realize had just been tested 1 or 2 days earlier in another setting, because the test result for that first event had not been reported into a central IT system that everyone in the provider community in South Carolina can look into. And I don't know if anybody wanted to sort of follow up on that theme or not, but as I think about the quality of data and the work that we're doing to develop more testing capacity, we certainly don't want to have situations where we're testing the same person 2 or 3 times in a relatively short time interval because we didn't have the IT infrastructure aligned in a way that would let us see that all in one place. And I don't know if Dr. Cole, you want to talk about that? I know we've talked about that somewhat.
Yeah, that was one of my points earlier. It's really critical that we get our tests in a reportable manner that are actionable. I mean, it's critical, and validation is certainly part of that. I think we have the capability, and we're getting the capacity, but we have to wrap our arms around it so that it can be used in an actionable manner. A test, as I said earlier, 100 tests in an isolated community that somehow just sits there is exactly what it does. It doesn't help anybody, really. So I think it's really important and component.
Can I just say one thing? I don't want to jump too far ahead. I know that the data is most critical at this time, accurate information with the surveillance in a central repository, but we've done this with overdoses in the last couple of weeks and turned that on to really have a targeted response once we know the data is accurate. We have a protocol and an alert system to communicate with the local community with very specific guidance for a local response. And that works well for us so far because we're really working in tandem with the locals, and it's not state-driven. but we're sharing the responsibility for a rapid response approach. So I just bring that up to say I hope, as we're talking about getting the data nailed down, we're thinking long-term on a system like that.
If I might jump in, that would be awesome. I mean, it's exactly what's needed. In fact, right now, I think as we're trying to wrap our arms around all these things, we need a rapid response capability to connect with the community and the local communities, again, in a manner that enables those leaders and faith leaders and or school members, whoever the leadership is. I think every community is going to be slightly different. It's really, we've talked about this too, a rapid response capability that gets the action items and or information to those that need to act is really critical.
So as I'm hearing that about kind of this database management and central repository, I'm looking on the screen at and out here at our research universities, and maybe some of the things in the collaboration that they're doing, if this is something that collaboratively that the research universities could look at doing in their work. Again, I'm not assigning tasks by no means to anybody, so I don't want, like Dr. Clements, to give me a bad look or anything like that. But at the same time, again, as I'm hearing that, you know, about the collaboration between our research universities, is this something, I mean, look, we've got a lot of really smart people in this state. We really do. And what are the ways we can engineer that ingenuity, that South Carolina ingenuity, to really find some solutions to issues like this? So I just bring up that point, as I know y'all have collaborated quite a bit.
Yeah, hey, Jim Clements here. I agree with those comments, and it's really nice to see USD and the University of South Carolina all working side by side on this issue, and we'll continue to do so in any way and shape and form that we need. One of the other comments earlier was about our extension service and helping people in rural communities and those who are underserved. Let's make sure we tap into that network when it's appropriate.
I wanted to mention as well that our college students in the state can always be recruited to be deployed as an army of volunteers if and whenever needed. Now, contact management will be largely electronic, technology-based, as we've been talking about, but I know there's a thirst on the part of the student government associations throughout the entire state, all universities, and even our private and independent college partners. So if there's ever a need at BHEC, for example, to do some contact management, telephone calling, texting, I think they would come together to help in an instant.
You know, that's a wonderful, wonderful suggestion. We've had, and talking about the furloughed healthcare workers, we're looking at possibility of teachers, particularly start talking about trusted individuals within the community, particularly the rural community. Teachers, along with the faith-based community, are those assets that we can reach out to talk to. I think Dr. Cole mentioned it, and you don't want to call it a SWAT team or a strike team, but you have to have that rapid response, particularly for those hot spots, and where we can mobilize more people, because we do need more people to get out there for contact tracing. So students, both from a nursing school, the technical schools, the universities, an excellent thought process that we will add to that in our array of what we're looking at for possibilities to expand the scope. We may have a contact tracing university, so a training program that we can put together and make sure we have the tools, and those tools often are people power, the boots on the ground. And so thank you for that one, and I think that's wonderful. And I'm going to take the prerogative to suggest a 5-minute break, and we'll come back and jump into some census tracts by rural geography, some very critical, important information. So a 5-minute break.